Infections. Typhoid. Etiology: causative organism, Salmonella typhi, paratyphi A and B. Source of infection, patient, carrier. Mode of infection, fecal-oral transmission. Clinical picture, incubation period 1 to 2 weeks. Clinical manifestations is divided into first week, second week, third week, and fourth week. First week, 3 general, 3 respiratory, 3 GIT plus rash. Fever, temperature rises in a step-ladder manner until reaching 39 to 40 degrees Celsius by the end of the first week. Headache, relative bradycardia, sore throat, cough, epistaxis, coated tongue, constipation, spleen is palpable, soft and tender, rash, rose spot, in 10%, side trunk, duration transient. Second week, the same as the first but severe, without rash. Fever, it increases continuously. Headache, decreases, and delirium. Tachycardia, coated tongue, splenic enlargement, diarrhea may occur, pea soup. Third week, whether complications or clinical manifestations start to improve. Fourth week, convalescence begins but relapse may occur. Clinical variants: afebrile, ambulatory, abortive, mild, grave, severe, pseudoral form, excessive sweating, localized, pleurotyphoid, pneumotyphoid, meningotyphoid. Complications: GIT, intestinal hemorrhage, perforation, peritonitis, cholecystitis. And then we have CNS, meningitis, encephalitis, peripheral neuritis, typhoid state, delirium and convulsion. CVS, myocarditis, chest, epistaxis, bronchitis, renal, pyelonephritis, glomerulonephritis, relapse. Investigations: CBC, elevated ESR, leukopenia with relative lymphocytosis, culture, blood culture positive in first week, stool culture positive in second week, urine culture positive in third week. Specific Vidal test, it's positive from the second week, and when the titer exceeds 1/80. Differential diagnosis: pyrexia of unknown origin. Treatment: prophylaxis, hygienic measures, case finding, isolation and proper treatment, immunoprophylaxis, TB vaccine. Treatment of carriers: ampicillin 6 gram per day for 6 weeks, and cholecystectomy may be indicated in resistant cases. Therapeutic treatment: general, rest, light nutrient diet, symptomatic antipyretics and analgesics. Specific for 2 weeks: chloramphenicol, ciprofloxacin, co-trimoxazole. Chloramphenicol 50 mg per kilo per day orally. Ciprofloxacin 750 mg per 12 hours. Co-trimoxazole 2 tablets per 12 hours, and all of them are given for 2 weeks. Treatment of complications: perforation, surgical treatment, hemorrhage, blood transfusion, and anti-shock measures. Side effects of ciprofloxacin: hypersensitivity, photosensitivity, nephrotoxic, confusion, headache, crystalluria, distension, GIT, superinfection, chondrolytic, reversible arthropathy. It's contraindicated in pregnancy, lactation, prepubertal children. Brucellosis, Malta fever, undulant fever. Etiology: causative organism, Brucella gram-negative Cucubacilli. Source of infection: Brucella metnesis in goats, Brucella abortus in cows, Brucella suis in pigs. Mode of infection: drinking contaminated milk, dealing with infected animals, farmers, veterinarians, or butchers. Clinical picture: incubation period 1 to 2 weeks. Clinical manifestations with the pneumonic brucellosis, and I'm not responsible for this mnemonic. Bone and muscle pain, relapsing fever, fever lasting for 10 days, then apyrexia for 10 days, then relapse, and so on. Constipation, nausea and vomiting, lymph node enlargement, enlarged tender liver, enlarged spleen, sweating. Clinical variants: intermittent, remittent, malignant, mild, continuous, localized brucellosis in bone and tests. Complications: relapse, infective endocarditis, orchitis, paraplegia due to transverse myelitis, and abortion. Investigations: lymphocytosis and elevated ESR in the CBC. Culture: blood culture positive during the fever spike. Serological test: Brucella agglutination test. Differential diagnosis: fever with lymphadenopathy and pyrexia of unknown origin. Treatment: prophylaxis, hygienic measures, pasteurization of milk. Therapeutic treatment: general, rest, light nutrient diet, symptomatic antipyretics and analgesics. Specific treatment: tetracycline or doxycycline or Septrin plus streptomycin or rifamycin. Tetracycline 500 mg per 6 hours for 6 weeks. Doxycycline 200 mg per day for 6 weeks. Septrin 2 tablets per 12 hours for 6 weeks. Streptomycin 1 gram per day intramuscular for 12 weeks, and rifamycin 600 mg per 12 hours. Then treatment of complications. Malaria, etiology, causative organism. 4 species affect mankind: Plasmodium vivax, oval, Malaria, and falciparum. Falciparum is potentially lethal. The others are usually benign. Source of infection: patients. Mode of infection: bite of female Anopheles mosquito. The life cycle is sexual cycle, asexual cycle. Sexual cycle, exogenous phase. In the female mosquito, they pick up gametocytes from infected individuals. Porocytes migrate to salivary gland to be injected into man. Asexual cycle, in man, endogenous phase, exoerythrocytic stage and erythrocytic stage. Exoerythrocytic stage, infected mosquito injects sporocytes which migrates to liver, forming merocytes which are released into bloodstream. Erythrocytic stage, merocytes invade RBCs, signet ring form, torphocytes. Rupture of RBCs, releasing merocytes which can infect other RBCs. Clinical picture, 1 to 2 weeks. Clinical manifestations, it's divided into benign tertian malaria, quartan malaria, and malignant malaria. Benign tertian malaria, infection by Plasmodium vivax and oval. The attack occurs every 48 hours. It passes into 3 stages: cold stage, hot stage, sweating stage. Cold stage lasting for 1 hour, acute onset of sense of coldness and rigors, rapid rise of temperature to 39 to 40 degrees Celsius, vomiting, polyuria. Hot stage lasting for 8 hours, hotness, headache, high temperature, flushed face. Sweating stage lasting for 3 hours, sweating with rapid fall of temperature with no or mild vomiting. Spleen is enlarged after 2 weeks. Quartan malaria, infection with Plasmodium malariae, similar to benign tertian malaria, but the attack occurs every 72 hours. Malignant malaria, infection with Plasmodium falciparum. It's divided into pernicious type, ordinary tertian type, and black water fever. Ordinary tertian type, clinical manifestations are similar to benign tertian malaria, but hot stage is prolonged. Sweating stage is decreased in duration. Splenomegaly is shortened in duration, Splenomegaly occurs within less than 1 week. Pernicious type, complicated, fatal. It's divided into ABCD, and I'm not responsible for this ABCD. Algid, malaria, abdominal pain, shock, hypothermia. Bilious, remittent fever, jaundice, vomiting, gastric pain. C. Cerebral malaria, headache, hyperpyrexia, focal neurological disorder, psychosis, retinal hemorrhage, irritability up to coma, severe thrombocytopenia. Dysenteric type, dysentery. Black water fever, complication of malaria characterized by intravascular hemolysis, hemoglobinuria, acute renal failure. Quinine, anti-malarial drug, play a role triggering condition, most probably autoimmune. Clinical picture: hemolysis, fever, rigors, anemia, jaundice, hemoglobinuria, dark red urine or black urine, loin pain, acute renal failure due to massive intravascular hemolysis. Complications of malaria in general: rupture of spleen, tropical splenomegaly syndrome, malarial hepatitis syndrome, which is mistaken clinically for viral hepatitis, nephrotic syndrome, especially in quartan malaria, and malignant malaria, complications of falciparum, pernicious malaria, and black water fever, hemolytic anemia, acute renal failure. It's very important to know that nephrotic syndrome, it occurs in quartan malaria caused by Plasmodium malariae. Investigations: detection of the parasite, blood film, bone marrow aspirate, CBC, features of hemolytic anemia, leukocytosis during the attack, serological tests to detect antibodies, therapeutic test, fever response to anti-malarial drugs. Investigations for complications: acute renal failure, differential diagnosis, fevers with rigors, and pyrexia of unknown origin. Treatment: prophylaxis and therapeutic. Prophylaxis: hygienic measures, anti-mosquito measures, insecticides, bed nets, repellents. Chemoprophylaxis when traveling to endemic areas: chloroquine 500 mg per week, 1 week before arriving, 4 weeks after leaving. Others: pramikine, mefloquine, and proguanil. Therapeutic: active malaria infection with falciparum, medical emergency requiring hospitalization, while with vivax, oval, or malaria it can be treated in outpatient basis. General: list light nutrient diet, symptomatic antipyretics, analgesia, specific anti-malarial drugs. Tissue: schizonticides against exoerythrocytic form to prevent relapse, pramikine and pyrimethamine. Then we have the blood schizonticides, treatment of acute malaria. They act on the erythrocytic form of the parasite and terminate clinical attacks of malaria. Chloroquine dosage: 4 tablets at first, and each tablet is 250 mg, then 2 tablets after 12 hours, then 2 tablets per day for 2 successive days. Side effects: corneal opacity, GIT irritation, etching. Contraindications: it should be used with caution in patients with hepatic diseases. Quinine dosage: 650 mg 3 times per day for 1 week. Side effects: synchonism, nausea, vomiting, and tinnitus, hemolytic anemia, miflucine, fansidar, combination of pyrithamine and sulfadoxin, 3 tablets as single dose, doxycycline, and clindamycin. Treatment of complications: black water fever, acute renal failure, dialysis, blood transfusion, and cortisone. Then we have infectious mononucleosis, glandular fever, etiology, caused of organism, Epstein-Barr virus, source of infection, carriers, patients, mode of infection, kissing droplets infection, clinical picture, incubation period 1 to 2 weeks, clinical manifestations, asymptomatic, fatigue, sore throat, tonsillitis, pharyngitis, fever, usually present, low grade, enlarged lymph nodes, spleen and liver, transient rash on amphiphilin therapy, periorbital edema, clinical variants, glandular type, aglandular type, febrile type, ecteric type, encephalitic type. Aglandular type and ecteric type, they occur in elderly patients. Febrile type, high grade fever, because normally it's low grade fever. Then we have complications: hepatitis, rupture of spleen, autoimmune hemolytic anemia, thrombocytopenia, meningitis, encephalitis transverse, myelitis, Guillain-Barré syndrome. EPV infection has also been proposed as a risk factor for development of multiple sclerosis, but this hasn't been confirmed yet. Investigations: lymphocytosis, monocytosis, culture, bone marrow examination, serological tests, anti-Epstein-Barr virus antibodies, specific monospot test, antibodies in human serum, agglutinate horse RBCs. Differential diagnosis: specific and pyrexia of unknown origin, treatment, prophylaxis, hygienic measures, case finding, isolation, proper treatment, chemo and immunoprophylaxis, therapeutic, general rest, light, nutrient diet, symptomatic, antibiotics, specific, no specific treatment, and treatment of complications. Fever of unknown origin, persisting elevation of body temperature over 38.5 for at least 2 weeks without diagnosis after proper history taking, physical examination, and routine investigations. You need to know types of fever: sustained fever, daily fluctuations less than 1 degree, remittent fever, daily fluctuations more than 1 degree, hectic fever, temperature falls to normal level once or more during the day, relapsing fever, short days of fever intercepted by short days of normal temperature. Normal body temperature, of course, is known, we are in faculty of medicine. Infections, 30%. Bacterial, the causes of unknown fever, infections, 30% of cases. Bacterial, TB, infective endocarditis, typhoid fever, brucellosis, lung abscess, pyelonephritis, septic focus, prostatitis. Viral, Epstein-Barr virus, cytomegalovirus, HIV, hepatitis, protozoa, malaria, and amoebiasis. Malignancy, 20% of cases. Hematological, lymphoma, leukemia, non-hematological, hypernephroma, hepatoma, bronchogenic carcinoma, collagen diseases, 10%, rheumatic fever, polyarthritis nodosa, systemic lupus erythematosus, and rheumatoid arthritis. Then we have others, 20%, sarcoidosis, pulmonary embolism, hemolysis, Crohn's disease, cerebral hemorrhage, atropine. Undiagnosed, 20%, most will resolve spontaneously. Investigations: elevated ESR in TB, collagen diseases and malignancy, CBC, leukemia and anemia, blood culture, urine and stool culture, Kift and Lift, liver and kidney function test, serology, Vidal test, anti-nuclear antibody, anti-DNA, imaging, X-ray for chest and bone, ultrasound, heart, abdomen, pelvis, endoscopy, upper GIT, lower GIT, biopsy, lymph node, bone marrow, liver, skin test, tuberculin test, therapeutic tests, metronidazole, amoeba, chloroquine, malaria, aspirin, rheumatic fever. Then we have differential diagnosis for fever with rash, viral infection, bacterial infection, autoimmune, and others. Others: rheumatic fever, SLE, rheumatoid arthritis. Others: leukemia, skin diseases, drug allergy, Steven Johnson's rash. Viral infection: ecdanthamata, measles, rubella, chickenpox, infectious mononucleosis, Epstein-Barr virus. Bacterial infection: septicemia, toxic shock syndrome, meningococcal meningitis, secondary syphilis, typhoid, Lyme disease, infective endocarditis, and ecdanthamata such as scarlet fever. Fever with relative bradycardia. Specific fevers: mycoplasma pneumonia, typhoid fever, and viral infection, influenza, viral hepatitis, and mumps. CNS lesions with increased intracranial tension, meningitis, encephalitis, brain abscess, intracranial hemorrhage, subarachnoid pontine hemorrhage. There is something that I have unintentionally missed, that we find relative bradycardia in the first week of typhoid infection, while in the second week we have tachycardia, and this is very important to know. Then we have fever with lymphadenopathy, bacterial, viral, and protozoal. Bacterial TB brucellosis, viral Epstein-Barr virus, cytomegalovirus, protozoal toxoplasmosis, autoimmune causes, collagen diseases, SLE, rheumatoid arthritis, malignancy, leukemia, lymphoma, granulomatous diseases such as sarcoidosis. Fever with jaundice, hepatocellular jaundice, obstructive jaundice, hemolytic anemia, malaria, black water fever, or hemolytic anemia whether congenital or acquired. Obstructive jaundice, Charcot's fever, cancer head of pancreas, calcular cholecystitis, liver secondaries. Hepatocellular jaundice, hepatitis, yellow fever, cirrhosis, Epstein-Barr virus, septicemia, drug hepatitis or viral hepatitis. And then we have differential diagnosis for fever with sore throat, local throat diseases, specific fevers, hematological diseases such as leukemia, neutropenia, and aplastic anemia. Specific fevers, diphtheria, infectious mononucleosis, scarlet fever, local throat diseases, tonsillitis, pharyngitis, Vincent's angina, pharyngeal abscess, or ulcers. Fever with rigors, I'm not sure, malaria, hemolytic crisis, blood transfusion, hemolytic or pyogenic reaction, miliary TB, septicemia, infective endocarditis, cholecystitis, cholangitis, liver abscess, subphrenic abscess, pyelonephritis, perinephric abscess, appendicitis, osteomyelitis, prostatitis, peripheral sepsis, salpingitis. So in conclusion, you're going to say anything with itis, liver abscess, subphrenic abscess, perinephric abscess, TB, septicemia, infective endocarditis, and all diseases in the gallbladder or liver with hemolytic crisis. Fever with abdominal pain, diffuse abdominal pain, localized abdominal pain, diffuse abdominal pain, secondary peritonitis, and spontaneous bacterial peritonitis. Localized abdominal pain, pyelonephritis, diverticulitis, splenic abscess, cholecystitis, cholangitis, appendicitis, hepatitis, any itis in the GIT. Fever with headache, heat stroke, sinusitis, brain abscess, allergy, cold and flu, meningitis. Fever with arthritis, septic arthritis, reactive arthritis, Reiter's arthritis, collagen and autoimmune disease, SLE, rheumatoid arthritis, and rheumatic fever. Associations of Epstein-Barr virus, arthralgia, lymphoma, chronic fatigue syndrome, and nasopharyngeal carcinoma. And then we have streptococcal infections. Streptococcal infections, diseases caused by it are pharyngitis, necrotizing fasciitis, pyoderma, cellulitis, erysipelas, pneumonia, bacillary dysentery, shigellosis. Symptoms of bacillary dysentery: abdominal discomfort, vomiting, dehydration, fever. Investigation, stool analysis and culture. Treatment, replacing fluids and salts with ciprofloxacin. Amoebiasis, investigation, stool analysis, 3 separate samples, sigmoidoscopy, serology by immune fluorescence. Treatment, luminal ambicidal, systemic ambicidal. Luminal quinolone kinase diloxanide, metronidazole or tinidazole, metronidazole 750 mg 3 times per day for 10 days, tinidazole 2 gram per day for 5 days. We have comparison between hyperthermia and hyperpyrexia. Hyperthermia, body temperature increases in an uncontrolled fashion, overriding the ability to lose heat, high fever. Hyperpyrexia can be high fever as well, exceeding 41 degrees. Hyperpyrexia, the body's temperature regulation mechanism, sets the body temperature above the normal temperature and then generates heat to achieve this temperature. While in hyperthermia, the thermoregulatory system during hyperthermia remains unchanged at normal thermic levels. Hyperpyrexia, severe infection, CNS hemorrhage. Hyperthermia, heat stroke syndrome, certain metabolic diseases such as hyperthyroidism, storm, and malignant hyperthermia. Hyperpyrexia, treated by antipyretics, physical cooling, treat on the underlying cause. Hyperthermia, physical cooling and not on antipyretics, treatment of underlying cause. Then we have the rest of infections: cholera, causative organism, Vibrio cholerae, classical and alter sources, patient or carrier, mode of transmission, fecal-oral transmission, indirect contamination of water and food, direct person-to-person transmission, which is rare, incubation period 1 to 5 days, clinical picture: the disease usually lasts for 3 to 5 days and ends whether by recovery or death. The disease may pass through 3 stages: stage of evacuation, stage of collapse, stage of reaction. Stage of evacuation: acute severe watery diarrhea, which is effortless, painless rice water diarrhea, vomiting of large volume, signs of dehydration, dry tongue, dry skin, low blood pressure, rapid weak pulse, marked loss of weight, muscle cramps, hyponatremia, sunken eyes, and inelastic skin. Stage of collapse, dehydration becomes very marked and severe, and it can lead to death due to hypovolemic shock or acute renal failure. Stage of reaction, dehydration is corrected, diarrhea and vomiting will stop if there is rapid fluid replacement, and because rapid improvement will occur. Complications, hypovolemic shock, hypoglycemia, hypokalemia, acute renal failure. Investigations, stool culture on TCBS agar, I don't remember the abbreviation, to detect the organism. Differential diagnosis, causes for acute watery diarrhea. For treatment, we have prophylaxis and curative. Prophylaxis, vaccination, tetracycline, 250 mg per 6 hours for 3 days. Curative, fluid replacement, tetracycline, 250 mg per 6 hours. For resistant strains, we give ciprofloxacin, norfloxacin, or cotrimixazole. Antidiarrheal drugs, loperamide. Then we have AIDS, causative organism, human retrovirus, HIV, human immunodeficiency virus. Sources, HIV positive person, carrier or patient. Mode of transmission, sexual intercourse, especially among homosexuals, vertical, mother to child, parenteral, contaminated blood. Then the incubation period can be weeks, months, or years. Pathogenesis, the virus infects T helper cells, leading to progressive depletion, leading to cellular and humoral immunodeficiency. When T lymphocytes fall below 200 cells per centimillimeter, the patient becomes at high risk to develop opportunistic diseases. Clinical picture is divided into 3 stages: acute HIV syndrome, asymptomatic and symptomatic. Acute HIV syndrome, fever, rigorous arthralgia, maculopapular rash, 2 weeks, resolves spontaneously and passes to clinical latency. Asymptomatic or clinical latency, latent period without symptoms, variable, and it can last about 10 years in average. Symptomatic stage, persistent generalized lymphadenopathy, constitutional symptoms, فاهم, with loss of body weight, chronic diarrhea. Neurological diseases, HIV, encephalitis, primary CNS lymphoma, myelopathy, neuropathy, myopathy. Opportunistic infections, herpes simplex virus, cytomegalovirus, mycobacterium avium intercellular, fungal infection, pneumocystitis carinii, pneumonia. Opportunistic neoplasm, Kaposi sarcoma, non-Hodgkin lymphoma, primary CNS lymphoma. AIDS in any person with HIV positive if CD4 is less than 200, or opportunistic infection or neoplasm, and this is an indication for treatment. Investigations, HIV antibodies bar ELISA appears within 2 weeks of infection. HIV antigens appear shortly after infection and before appearance of antibodies. Treatment, prophylaxis, prevention, curative, antiretroviral treatment, zidovudine 600 mg per day orally, and it's called highly active antiretroviral therapy, HAART, HAART. Again, it's zidovudine, 600 mg per day. Treatment of opportunistic infections and malignancies. Giardia lamblia, metronidazole, 250 mg 3 times per day for 5 to 10 days. Tinidazole, 2 gram once. Atibrine, 0.1 gram 3 times per day for 5 days. Then we have ankylostoma duodenal, flubendazole, thiabendazole, parenteral palmate, levimazole, bifinium hydroxyl naphthoate, and don't forget treatment of iron deficiency anemia. Flubendazole, 200 mg twice daily for 3 days. Thiabendazole, 25 mg per kilo daily for 2 days. Parenteral palmate, 11 mg per kilo once. Levimazole, 150 mg once. Bifinium hydroxyl naphthoate, 5 gram once. And then we have entropius or oxyrius vermicularis. Antiparasitic treatment, the same: flubendazole, thiabendazole, parenteral palmate, levimazole, pyrivinium palmate, and piperazine. Flubendazole, 100 mg once. Thiabendazole, 25 mg per kilo daily for 2 days. Parenteral palmate, 11 mg per kilo once. Levimazole, 150 mg once. Pyrivinium palmate, 5 mg per kilo once. Piperazine, 300 mg per day for 7 days. Second dose given after 2 weeks to treat auto-infection, and is better to treat all family members. Local measures: mercury ointment to kill females, local anesthetic, to prevent itching. Hygienic measures: cut the nails, boil clothes and linens. Filariasis: diacyl carbamazepine 2 mg per kilo 3 times per day for 3 weeks. Hymenopus nana, niclosamide 2 gram daily for 7 days. Praziquantel 25 mg per kilo single dose. Atibrine 100 mg 3 times per day for 7 days. Again, it's hymenopus nana, niclosamide, praziquantel, atibrine 2 gram daily for 7 days. Niclosamide 25 mg per kilo single dose. Praziquantel 100 mg 3 times per day for 7 days. Atibrine. Treatment should be repeated after 2 weeks, such as vermicularis. Then we have Tinea solium and Tinea saginata, niclosamide, praziquantel, and atibrine. Niclosamide 2 tablets, followed by another 2 tablets by 1 hour. Praziquantel 10 mg per kilo single dose. Atibrine 10 tablets, followed by saline purge after half an hour to expel the worm and the drug. The head of the worm should be searched in the stool. Side effects: jaundice and GIT irritation. Hydatid cyst. Membendazole 40 mg per kilo per day for 6 to 12 months, or albendazole, but most importantly surgical excision. Fasciola: bithionol, praziquantel, bithionol 50 mg per kilo every other day for 10 doses. Praziquantel 75 mg per kilogram in 3 doses 1 day. Then we have schistosomiasis: praziquantel, oxaminiquine, metrifonate, niridazole, and finally antimonials. Antimonials are no longer used. Praziquantel, the drug of choice for all types of schistosoma. Dosage 40 mg per kilo orally, single dose. Side effects: headache, dizziness, nausea, vomiting, diarrhea, myalgia, rash. Oxaminiquine, drug for Mansonae only, 20 mg per kilogram orally for 3 doses. Metrifonate for hematobium only, 10 mg per kilo orally, repeated every 2 weeks for 3 times. Niridazole, effective against hematobium and Mansonae, 25 mg per kilo per day orally for 7 days. Side effects: headache, dizziness, nausea, vomiting, convulsions. Ascaris lumbricoides: flubendazole, cybendazole, pyrantel palmate, levimazole, and piperazine. Flubendazole 200 mg twice daily for 3 days. Cybendazole 25 mg per kilo for 2 days. Pyrantel palmate 11 mg per kilo once. Levimazole 150 mg once. Piperazine 3 gram once. And then we have severe acute respiratory syndrome, coronavirus 2. It's a novel ssRNA coronavirus and the cause of the ongoing COVID-19 pandemic. Spreads primarily through respiratory droplets and aerosols. Host cell entry occurs by attachment of viral spike protein to angiotensin converting enzyme 2 receptor on cell membranes. Clinical course: it's different whether asymptomatic or symptoms including common fever, dry cough, shortness of breath, fatigue. More specific, anosmia, loss of smell, and altered taste. Potential complications include respiratory failure, hypercoagulability, shock, organ failure, death. Risk factors for severe illness or death include increasing age, obesity, diabetes, hypertension, chronic kidney disease, and severe cardiopulmonary illness. Diagnosed by RT-PCR or antigen and antibody tests, which are available, but the most common is PCR. Treatment options for hospitalized adults include remdesivir, nucleoside analog, convalescent plasma, and dexamethasone to treat cytokine release syndrome. Then we have the diagnostic approach for fever plus headache. We have to exclude CNS causes, which are presented by headache, projectile vomiting, blurring of vision, and with examination there is neck stiffness, signs of meningeal irritation such as Kernick sign and Lazago sign. Investigation: CT, MRI, lumbar puncture. Other causes: common cold, allergy, bacterial infection, post-vaccination, heat stroke, rheumatoid arthritis, and antibodies. And this concludes infections.